Let's consider making the diagnosis of HAE with normal C1 inhibitor. It's critical to understand that HAE normal C1 inhibitor is real and that failing to make the diagnosis can lead to significant morbidity and even death. Yet, we have to also keep in mind that HAE normal C1 inhibitor is often overdiagnosed, leading to patients being treated with inappropriate medications. Red flags suggesting a possible misdiagnosis include use of multiple HAE medications on a schedule inconsistent with HAE and lack of clearly documented significant angioedema. The clinician is faced with the problem that there is no definitive biomarker for confirming or excluding the diagnosis. You've outlined the current diagnostic approach, but it's important to recognize that this is suggestive and not definitive. HAE normal C1 inhibitor is incompletely distinguished from HAE C1 inhibitor by a somewhat later age of onset, a female preponderance, and a less striking family history. For patients who fail to respond to aggressive mast cell-directed therapy, we suggest a limited trial of the B2 bradykinin receptor antagonist icatibant. A clear and durable response to icatibant strongly points to a bradykinin-mediated rather than a mast cell-mediated pathogenesis. We suspect that HAE normal C1 inhibitor is a bradykinin-mediated disease, but unlike HAE C1 inhibitor, where the mechanism has clearly been shown to involve activation of the plasma contact system, how bradykinin is generated in HAE normal C1 inhibitor remains mostly uncertain. At the UCSD Angioedema Center, we screen suspected patients by sequencing the genes associated with this disorder. We also developed a biomarker we call the TISCA assay that appears to identify patients with bradykinin-mediated angioedema. This assay is still in the investigative stage and more work remains to be done. In patients we presumptively diagnose with HAE normal C1 inhibitor, the mainstays of treatment are avoiding exogenous estrogens, early use of icatibant for angioedema attacks, and consideration for prophylactic treatment with either progesterone or tranexamic acid. Future studies will establish the efficacy of other medications, such as those directed against plasma kallikrein or factor XII.